Aloha! The CME activity is jointly provided by the Queens Medical Center and UH-JABSOM Department of Geriatric Medicine. We offer free continuing education for this series. In order to receive a CME or CEU, participants must complete the online evaluation at the end of the webinar. Your comments are very important to the planning committee and will be used to plan future programs. Health professionals, you can now check on your CME credits online. Go to www.queens.org and type CME in the search tool. Click on My CME Transcript, then sign in to generate your transcript. We want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO motto goes, all teach, all learn. So it will take all of you to create this community of learning. In the spirit of aloha, we encourage that you turn on your cameras to help us build a community of learning. Feel free to eat during this session. Good nutrition is key to a healthy lifestyle. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open the time up for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to the topic of today's lecture. We only ask that you keep it HIPAA compliant case for discussion. That means please do not share the patient's name, birth date, address, and so on. We learn best from our patients. They are the best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I am Wynette Gaylord of Alliance of Residential Care Administrators, ARCA. We have Mary Botan, President of Foster Family Homes Association, Elsa Talavera, President and CEO of All Island Case Management Corporation, May Magnayan, nurse from Lokahi Case Management, and Madeline Kim, social worker student and CHW at Aloha Care. Leila Ventar, health coordination manager from United Healthcare, Kauai County, and Dr. Rita Bell Fernandez from University of Hawaii. We are in the first month of our series on mobility. If you're interested in viewing any of those lectures and handouts, you can find them on our website. Unfortunately, we cannot offer certificates of attendance for videos you have viewed. You must participate in our education live. The title of today's webinar is Physical and Chemical Restraints. Joining us today is Dr. Aida Wen. Dr. Wen is professor at the Department of Geriatric Medicine, John A. Burns School of Medicine, JABSOM, University of Hawaii, and is a board certified in geriatric medicine and hospice and palliative medicine. She is a geriatrician at the Queen's University Medical Group with post-acute long-term care and is the program director of the Geriatric Medicine Fellowship at JABSOM. She is also a consultant for Aloha Care in the Division of Long-Term Services and Supports. She is a strong advocate for improving geriatric and dementia care, striving to help patients and providers help seniors age as gracefully as possible. As the principal investigator for the HRSA-funded Geriatric Workforce Enhancement Program, GWEP, she has developed a wide network of collaborators and partners with schools, clinical sites, and community organizations to expand the capability of providers and caregivers who can build the age-friendly health systems through interprofessional and geriatric care. We are grateful for your time and expertise and for the important work you do to for the community support. We're delighted to have you with us today. Welcome, Dr. Aida Wen. Woo!
Okay, yeah, now we're on. Yeah, I'm excited to be back. It's been a little bit. But I'm really pleased. Okay, so great topic today, physical and chemical restraints. Next slide. Have you seen these scenarios? The guy's saying, "Help me, I need to use the bathroom." Right? Or trying to climb out of bed constantly, calling out to use the bathroom every 15 minutes, or scratching their skin, trying to pull off their bandages, pulling out their tubes, Foley catheters or IVs or anything, oxygen, right? Wandering and pacing or hurting other people. Would you say these are challenging? Yes, yes, we've seen them all. Well, the problem is he's not just saying, help me, I need to go to the bathroom, right? Now, this guy here is banging at his tray. He's saying, help, I can't take this thing off, get me out. So, why is he doing that? Because he has a restraint. So, what is a physical restraint? It's a device that limits a person's movement. For example, wheelchair trays that keep people in a wheelchair. And the inability to remove the device is a defining feature. So it might seem like pretty benign. It's like, yeah, we'll just put the tray on and no problem. But actually, if the surveyors came around and saw this, they would say, oh, this is a physical restraint because this man cannot remove the device on his own. Okay, and then there's some things that, well, if we don't use physical restraint, how can we get him to stop trying to get up and move around and, wander and fall? Then well, let's see, let's get some medications, right? But which sometimes could be appropriate, but oops, go back. But if it's used, and medications are supposed to be used to treat an illness, but if it's used to make people sleepy and make them easier to handle, that's a problem, right? So restraints should not be used for convenience, right? And restraints should not be used for punishment. So there's the fine line over there that we need to be aware of. Next slide. Yeah, so here are some examples of some physical restraints, which I'm sure you've seen before. Um, right, there's the vest restraint. We put on the vest and then you tie the thing to the back of the chair, or a waist restraint, or a lap restraint. There's that wheelchair tray. There's hand mittens so that you kind of put them, and then they can't actually grab anything with that, right? So they can move their arms around, but they can't actually grab or hurt that way. And then there's the hospital bed. So there is a difference between half rails and full length rails that I just wanted to point out. So if there is half rail up, so say we have just the top part that's up, but the bottom parts are down, they can use the top half of the rails for mobility. They can grab it to turn on their side or the other side, or they can use it to help them steady themselves as they're sitting up in the bed or trying to stand and just helping with mobility. That's okay. That's not considered a restraint. It's actually just helping them. But if you have four rails up, then they can't get out of bed. In fact, and so they can't move it, and so that is considered a restraint. In fact, the problem with especially with these full rails being up is that they're still going to try to get up. And what do they do to get up? Well, they scooch themselves to the end of the bed and they try to climb over the handrails or the bottom or the top or whatever it is. And that results in more injuries. So they will either get their legs or their arms entrapped in between and get bruises or tears. Um, or they'll fall from a higher length and they might injure one of their extremities or somewhere else. And the other thing I've seen problems with is these restraints, right? Whether it's a vest restraint or a waist restraint, or even in the bed, that it creates a false sense of security. We say, oh, they're restrained, so I know they're going to be safe. But, I've seen people they're in bed and then they scooch down and they scooch down and they scooch down. And before you know it, the restraint is on their neck, right? And they're down and it's causing a choking hazard, right? Or if the restraints are too tight, can cut circulation. Some people die from restraints as well, which is really terrible. So, um, if you ever use a restraint, do not assume that they're safe because they may not be. In fact, they may be even more agitated. Restraints can cause psychological trauma because if you were tied up, right, you feel like you have no dignity, right, can cause stress and may worsen agitation or recall PTSD, or if they've been tied down before under different circumstances, or create PTSD. So restraints are not something to take lightly, and we have to do our best and be as creative as possible to try to figure out not how not to use a restraint. Next slide. In fact, there's a Nursing Home Reform Act in 1987, right? The OBRA that we all got drummed into our brains, right? It's about abuse and neglect. And so the idea behind this one is that residents under our care need to be free from abuse and neglect, free from restraints. We need to protect residents from physical or mental abuse, chemical or physical restraints. Use for discipline, convenience, or part of routine care is unacceptable. Those are considered abuse. In fact, what are some signs of abuse, right? If you see unexplained injuries, like fractures or bruises or cuts and skin tears, sores on wrists and ankles and places they shouldn't be, sudden behavioral changes, like they're suddenly more withdrawn, more fearful, more lethargic, particularly around certain people. You have to really be just open your eyes a little bit and try to see if where they might be having this trauma from. And then there's also neglect, right? So not, like I said before, people assume people are quote unquote safe, but so they're not checking on the restrained person. And when you do that, it can result in bed sores, loss of mobility. They get more and more deconditioned, right? Eventually they're bedbound, right? Can cause weakness from that deconditioning, unexplained weight loss and dehydration. So we really have to be very careful with this. Next slide. So, so there are limits on restraint use, right? And so really restraints must be used only as a last resort, right? And we should limit that use only to the movements that cause harm. So if they're actually just trying to pull out their IV or their tubes, maybe a mitt, the hand mitt might be sufficient, right? Because you don't need to tie their legs. You don't need to tie their arms. Don't need to prevent them from standing up, right? So you just prevent them from actually grabbing the thing. Or if they're scratching, right? Then you say, well, maybe socks, right, on their hands, right? They can still move their hands, but they can't, cause themselves an infection in their skin from this and bleeding from scratching, right? So use it for limited as best as possible and use for the least amount of time. If they're sleeping and they're not scratching, no need, right? And then ongoing re-evaluation to reduce or eliminate the restraint as soon as possible. In fact, if you can only put on a restraint if you have a physician's order for it, right? And you have to, so if the doctor has to give an order, but the doctor actually has to document what type of restraint, not just, oh, restrain them, right? Well, what specific kind? And they have to describe the symptom we are treating. Agitation doesn't work, right? What specifically are we treating? Oh, we're trying to treat them from, we want to prevent them from scratching or pulling out their tube, so they have to be very specific at what we are trying to do here and the circumstances for it, because when the circumstances pass, we don't use it, right? And then also the duration of use and okay, I'm going to recheck this in about 48 hours and see if he's a little better or whatever, right? There also needs to be consent, informed consent from the resident or their legal representative. We need to explain the risks, the benefits, and the alternatives. Did we try other ways without restraining them? Did we try absolutely everything? We ran out of options. This is a last ditch effort, right? So other methods must be tried first, and we have to document your procedure for monitoring. So how frequently are you monitoring them? Should be like 30 minutes or something like that, right? Every 30 minutes. And have protocols for release breaks. So release them, do some repositioning so they can get up their butt, won't get any pressure sores, maybe for turning, maybe for exercise, toileting, activities, or hygiene, hydration, but you got to move them around frequently. Otherwise, they are going to have more problems. So, um, in fact, if you do that, you might wind up having to do more work, right? Because you have to be constantly checking on them, which you should be anyway. So that's those are the requirements for restraint use. You have to medically justify it and tell the doctor what exactly you are trying to do that needs it. And so the doctor can actually write that in their notes as well. Next slide. So some ideas for these release breaks, right? You can do chair exercises, right? Sit in the chair and do exercises and move around. Chair dancing, you can do that too. You can do sit to stand exercises. You can do standing and then getting on your tippy toes. Those are heel raises. You can march in place, anything to move around because the biggest risk is weakness and deconditioning, right? So, and maybe taking the opportunity to walk them or take them to the toilet every break. Or, the other problem with restraints too is, yeah, I mean, like chemical restraints is if you don't feed or give them fluids because they don't have access to it on their own if they're restrained, then, yeah, lots of frequent snacks or fluids or hygiene and things like that. So yeah, these are just basic ADL things, but also activities and exercise and snacks and hygiene, all good stuff. But make sure that you do a little bit each time, every 30 minutes, every hour, every 2 hours. You got to keep it up. Next slide. Okay, so chemical restraint, right? What is that? That's the use of prescribed drug to treat an illness. So like using a pain medicine, not for pain, but to make them go to sleep, right? Or depression medicines, right? At higher doses so they fall asleep, right? Not necessarily for treating the depression. Seizure medicines, or if they're having hallucinations, right? So just using the prescribed drug, but giving them at higher doses to make them sleepy is considered a chemical restraint. Um, so yeah, you need to let your doctor know if the doses that they are prescribing are actually too high, because they're not necessarily going to know, because you're the one seeing them in action. Is the dose causing too much sedation? And then maybe they can back up because you want them to be able to be awake or at least, arousable, not totally asleep. Otherwise, they are going to have a lot of bad effects. Like, especially if they're too sleepy, you can't arouse them. Poor food, fluid intake, weight loss, functional decline. And if they're sleeping all day, they'll be awake all night. And long-term use of these kinds of things will worsen your brain, right? Brain turns to mush, worsen cognitive function, more agitation. And then, of course, not to mention that you can get the stiffness and the movement disorders. I've seen people uh, aspirate, because they're too sleepy. So even though when they're awake, they don't have a problem, but when they're sleepy, that's when that happens. Or some of these medicines, like that cause sedation also make your blood pressure drop as well. So low blood pressure can also happen. So there's a lot of things to consider with that. Next slide. And actually, the use of antipsychotic medicines, even at quote unquote regular doses that are not causing them to be sleepy, um, are problematic as well. For example, like things like Haldol, Risperdal, quetiapine, which is Seroquel, things like that, even at doses that don't cause them sleepiness, they have bad effects on the body. They can cause diabetes, make your blood pressure go higher. You can increase your cholesterol, cause weight gain. And then that also, there's an increased risk for heart attacks, stroke, and death. So they really should be avoided anyway, and also used as the last resort. Now, next slide. And so it should be avoided as much as possible. And the other problem, and you may have seen this, is it causes movement disorders, right? So these can cause people to look like they have Parkinson's, even if they don't, because the medicine is causing them to have tremors and shuffling when they're walking, or their movements are getting more slow, or they get more restless, or they're twisting, or having contractures, involuntary movements, tongue thrusting, mouth smacking, blinking, twisting arms or legs, and it looks like they're very, very restless. Those can be the medication side effects and really need to let the doctor know so you can say, no, no, this medicine is no good for this patient. So let's avoid it if we can. Next slide. And the benzodiazepines are things like lorazepam, which is Ativan, right? They're also bad at regular doses, even if it doesn't cause too much sleepiness. They use it to treat anxiety, and it does cause sleepiness. And so that's in a way why it works, right? Because they won't be feisty anymore. But it also causes chemical dependence, and people can get addicted to this, and body's gonna need it. So really want to not use this at a regular basis. And it's associated with risk for more falls and what we call rebound anxiety, because people develop this dependence on the drug when the drug wears out of the system and the doses get really low. They can get even more anxious than when they started in the first place. So it's called rebound, right? Um, so that's another reason why we don't want to use benzodiazepines if we can help it. So next slide. So what are the alternatives? So behavioral interventions, activities and socialization, and environmental modifications. All right, let's go explore these a little bit. So I always love talking about this. This is, you know, try a behavioral approach, right? When you have a toddler who's acting out and throwing a tantrum, your first move is not to reach for Ativan, right? Or Risperidol or another drug, right? You try to figure out, oh, what do they need? Maybe they're hungry, maybe they're cold, maybe the room is overstimulating, maybe they're bored, maybe they're anxious about something, maybe they're lonely, So look for the unmet needs. Could be physical, could be emotional, could be social, right? Um, and so you have to address those basic needs. So a lot of times, I mean, we have plenty of residents where they're acting out, and then you're like, oh, I know, snack. Snack works all the time, right? And then you come and bring them a snack and have a seat. Look, I brought you a snack. And they're very happy to sit down and enjoy their snack. And the next thing you know, they've forgotten about whatever they were agitated about, right? Addressing basic needs, reassurance and redirection. Um, because oftentimes um, folks with dementia are stimulus bound, meaning that whatever's in front of them is what they see, right? And that's the only thing that matters. And so you got to like, oh, whatever's in front of them is disturbing them. You got to take it out from in front of them, right? Out of sight, out of mind. Let's reassure them everything's okay. Let's go do something else. Let me bring you another puzzle. Let me bring you a newspaper. Let me bring you, oh, let's go talk to so and so. Let's go look at the flowers, right? Redirection. So whatever's in front of them, they will be distracted towards. Um, I'm aware that sometimes, the attention span is short and the intervention only works for 15 or 20 minutes, and then you got to go find another one. But still, that's what we need to do, right? And then the best friends approach, which is if you treat people like your best friend, they will respond in kind, right? So you be very smiley and friendly and open and, very safe and, well, accepting and warm. And, you know, that approach works really well because they do respond to emotional needs being met. And I also want to just say again that TADA stands for tolerate, anticipate, and don't agitate. So if they're doing a behavior that isn't hurting anyone, it's okay. They keep doing it. It's all right. You might be annoyed, but it's not hurting anybody. Leave it be. Just let them do it. Tolerate it, right? Anticipate if you know that it's coming along 3 o'clock and, there's a change of staff. You should anticipate this and get them out of the main area before all chaos starts happening, right? Uh, and get them in front of their favorite movie or something before that all happens. Anticipate it and then don't agitate it. If you know there's something that's going to bother them, like don't do it. So it's that simple. But, all of this requires extreme creativity, right? What other alternatives do we have? Next slide. Environmental changes. So if they are being unsafe and trying to get out of bed, instead of tying them down, maybe we put a chair alarm or a bed alarm, a tab alarm, or you put a low bed. Put the bed near the ground as much as possible so that if they fall, it's a non-injurious fall. They won't injure themselves that much. They won't break anything. So a little mattress and a low bed, and if they roll out of bed, no problem, right? We can get them back in bed and they're not injured. So these are other environmental changes to try rather than tying them, So uh, next slide. And, just keeping them. So, yeah, it's 24/7. It's keeping them busy and active while awake. If they are bored out of their mind, they are going to look for trouble, look for things to do. So, always have something up your sleeve. It's like, oh, they're bored of this activity now. Let's see. I know what's next, right? So you can constantly be aware to switch out the activities, things like that. So, right, which exercise is always a good one if they will do it with you. Sometimes, of course, they'll say no. That happens plenty time, right? But then if you start exercising and you start throwing balloons or whatever it is, if you start watching the video with the exercise lady, they may actually sit there and watch it and then join in. So you never know. You just got to try it, right? Um, or you take them out for a walk if it's a little bit more passive. You know what? You need a change of scenery. Let's go outside. Next slide. Okay, here's the interactive part. I'm going to ask you guys. These are the same scenarios that we talked about that we see all the time. What would you do, right? Without a restraint, right? Trying to climb out of bed constantly. So please unmute, share, put stuff in the chat box. I'm looking for creative answers. See who wins the creative answer prize. I'm sure you've seen this. What do you do with the resident trying to climb out of bed constantly?
Okay, so mine is if they're trying to get out of bed, I actually get them up out of bed to make sure that, yeah. And then if it's daytime, I normally bring them to the dining room, and food works all the time. And so put food in the front of them. And normally that's a good distraction.
Yes. I see here, right? Vilma says, give snacks. Same answer. I think a lot of people have the same answer, right? It's a great distractor. And actually, they might be hungry, right? That midnight, how many of you guys have midnight snacks, right? Redirect them. Offer the bathroom, right? How many times does that happen, right? They actually fall out of bed or climb out of bed on their way trying to go to the bathroom, and then they have an accident because they're just bladders full. Yes. Offer the bathroom, right? Try to take care of these basic needs. I give my patients clothes to fold. Good job with that. That works too. Oh, when food doesn't work, what are we going to do? Hmm. Any ideas, folks? Okay, organize plastic utensils. Right, which means that instead of trying to keep them in bed, right, and tell them, no, 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 go back to bed, it's nighttime, go back to sleep, get them out of bed and give them an activity. And if they can walk, walk with them around the house or the garden, play cards, walk with them if they can, give them something to do, play, do puzzles. Yeah, yeah. Walk them around the house till they are tired. Yes. Walking is good anyway. Make them exercise to make them tired. Get them in the chair, fold clothes, wash clothes, talk, make stories. Yes. Get them tired, talk story. Good. Yeah. Folding laundry is the best. Okay. Yeah. Great. How about what if they're calling out to use the bathroom every 15 to 30 minutes? You say, no, I just took you to the bathroom. Ah, they might have a UTI if they're asking many times. Right, right. So, what should we be doing instead? Redirection and assess for UTI. Yep. Hey, doc, this is more than usual. Something unusual is going on. They seem to be more agitated and trying to use the bathroom. Can we get a urinalysis? Right. Let the MD know. Let's reassess this thing. Mm-hmm. Check their last bowel movement. Oh, you guys, you've seen it. You've seen that happen, right? They haven't gone for like a whole week, right? They came back from the hospital and they didn't check, and last time they used the bathroom and they're stuck. Yeah, so they constantly feel like they have to go. Okay, what else? Calling to use the bathroom. You know, the other thing I was just thinking is, yeah, letting the MD know because sometimes if the doctor just changed a medicine or added a new medicine, sometimes the medicine can cause people to want to go to the bathroom, right? So, yes, you can say, oh, yeah, the new thing that happened is we started this other medicine or something like that. Could that be causing it or making it worse? Yeah. Sometimes only in mind and scared to make an accident. Yeah. Make them use it every 2 hours. Absolutely, right? It's called scheduled toileting, time toileting, right? So instead of waiting for it to become an emergency and they have to like, get there like now, um, take them to go even when they don't have to, right? Who's been potty training, right? Who's done this for their kids, right? You don't wait till they have to go. You just keep taking them. You look at your watch, you set an alarm, you say, okay, every 2 hours we're gonna go. And they say, but we don't have to go. And say, no, just try, right? And then oh, lo and behold, they have, right? Don't offer fluids late in the afternoon. Absolutely. Yes, absolutely. And divert their attention to other stuff. Now, oftentimes as people get older, right, we have something called detrusor instability, where the bladder actually isn't that stable and it just has these spasms and it contracts. And so that's why there's those bladder medicines that you have. You've seen those before, like ditropan and things, oxybutynin, right? Or a Myrbetriq or something like that. So it might be something to try, but you have to talk to the doctor about assessing them for that first, before trying any medicine, right? Because it could be a different cause. But those are important things to note as well, because they can be managed. So sometimes, yeah, I do use medicine for that. And I divert their attention to other stuff. Yes. Have you noticed that there's some residents that they constantly have to use the bathroom until they're in activity? And when they're busy and there's a show going on and there's whatever, right? The special guest or whatever, they suddenly don't have to go to the bathroom for a little bit longer. So yeah, divert their attention, diversion with distraction. Mm-hmm. Yeah. What else? Oh, they might have pain. You know, I had a patient like that just recently, constantly restless, actually was get up from a chair, go walk to the other chair, sit down, get up, walk to the other chair and sit down, get up, walk back. And finally, when we get them in bed, no more pain. They don't want to get up. I was like, oh, it was pain. Let's give them Tylenol, right? And yeah, we check their coli and see a little bit redness. It's like, oh, that's the problem, right? Because they can't tell you that their butt is sore, but yes, they have pain, but cannot express. Absolutely. Another reason they're climbing out of bed, climbing out of the chair, right? Right. Scratching their skin, pulling off bandages. These are all, right? Oh, nails, be kept short and smoothly filed. Absolutely. Put on lotion. Imagine that. Dry skin will make people scratch. Mm-hmm. Different kinds of lotion too. Not if the regular moisturizer doesn't work, then you use the anti-itch moisturizer, right? Because that actually has ingredients in there to reduce the irritation, right? What else? Then you put on clothing with long sleeves, right? Or jerry sleeves, right? So that then they can't go and scratch it directly. So even if they scratch, they won't. Yeah, it's stressful to keep their hands busy, right? Holding on to things, give them things to hold, right? And then soft things to hold, right? And yeah, a fidget item. I have an engineer guy, and he loves those fidget tool things. Hmm. Great. Anything else? Scratch. With the doctor's order, use mitten. Yeah, can. But be always mindful of when do we, you know, what's the problem with the mitten if they have it? What are they at risk for? Yeah, their hands can get stiff, right? They can't go and grab something to drink, right?
Oh,
Yeah, they can't go grab food. They might get dehydrated. They can't use their hands. Yeah.
Excuse me, madam.
Yes.
I I have a scenario that kind right now, and
Yes.
do we have to write an incident report if your patient is scratched a lot on her buttocks?
Mm-hmm.
Yeah, because
Yes.
no matter what I do to her, the the doctor gave her the medication and everything, but when I check her every 30 minutes, she's so quiet. Then when you time for her to change the diaper, oh my God, she's really scratched a lot. So
Yeah.
she scrape her butt too deep. So that's the one I'm doing right now. So my CMA told me to write incident report.
Yeah, because the scratching was so severe. I have plenty of residents who scratch, right? So I think the important thing do, yes, mo definitely monitor for wounds, right? That they have to monitor that pretty carefully. Uh, but we have to get to the underlying cause for the scratching. Why are they scratching,
Yeah,
right?
sometimes I ask the client, I said, why do you scratch? She said, she will answer me, I'm sleepy. I feel itchy, so I scratch.
Mm-hmm.
That's what she
Yeah.
said.
So,
Uh, I
yeah.
did everything. I talked to the family. The family told me put mittens. So I tried mittens, but she can take it out.
Yeah.
I
Yeah.
I,
But mhm.
I even make a jumpsuit so that she cannot scratch her butt, but she will pull up the pants, just like the pants, until it will reach to her groins, and she will scratch again.
Yes, yes. I like Mason's comment here. This is something we need to inform the doctor because the
Yeah,
client might be allergic to the food or fabric. That's what I mean by got to get to the bottom of this. If it was you and you were itchy, right?
yeah, yeah.
Yeah.
The doctor changed her medicine and everything. I even when she get a bath, then when I clean her, I use Dove soap.
Mhm. Yeah. So,
So I don't know, just like a habit for her because every time you change her diaper, she will scratch. I even trim her nails almost every day, file it,
yeah.
and still she can scratch it so deep until it
Yeah.
will bleed.
Sometimes well, there's a lot of different causes, but sometimes scratching is neurologic. The nerves are just sensitive and they're just going off, kind of like seizures, except they're just kind of itchy kind of nerves. And I had a patient and she would not stop scratching. There was nothing. So after trying all the different lotions and everything, I actually put them on a small dose of seizure medicine.
Mm.
you know,
She got
or
the
lidocaine gel even. And that seemed to calm the nerves down so they didn't scratch so much. So, definitely, but sometimes you have to do that. I have also noticed this that hygiene, when there are some patients who just get bed baths, they may be more itchy than the people who have a really good shower. So
yeah.
sometimes
Even though she's on the shower, she scratch. We just give
yeah,
her shower still. So So the nurse while I said, "Oh, she went scratch again. I don't know why."
So Zaya
Yeah,
says it could be related to moisture and skin irritation from brief use and incontinence, causing discomfort and scratching behavior. So sometimes I just say, okay, you know what? No more bed baths for you. You have to have shower at
yeah. She
least twice
always
a
need
week,
shower down.
at least a week, because, and then
Yes,
definitely dry skin, moisturizer more than daily, twice a day, three times a day, you know. And then not just moisturizer, the anti-itch moisturizer too.
they get the Sarna lotion down.
But Sarna, but there's also anti-itch
Yeah,
because they
you get.
have things in it like the menthol and things. So it's sometimes you gotta, but keep at it. Don't give up because itching is
Yeah,
very
I
uncomfortable.
like cry sometimes when I see her scratching because she will
Yeah.
scratch it until it will bleed. The
Yeah.
doctor just give her a Loratadine in the morning and gabapentin nighttime. They just changed the Atarax because the Atarax not working.
Yeah. Yeah.
I
So yeah,
don't
the
know until
gabapentin is the anti-seizure medicine, right?
yeah, that's the
That
one I
that's
give
used. Yeah.
nighttime.
Mm-hmm.
But
Okay.
until now, I don't know. It's not working.
Well, don't give up. Keep bothering the doctor. Keep trying because you got to do something. My resident was itchy a lot before, and the doctor told us to change the hypoallergenic laundry soap. Absolutely. I always use that because too much scented stuff is, yeah. Skin repair lotion from the midline. Skin
Yeah.
repair lotion. It's just that the moisture helps them repair
Yeah,
the
every
skin.
time I wash her, I use the Dove soap. But it's
Yeah, Dove soap,
still,
but referral to dermatologist. Absolutely. Don't give up on the patient. Get that. Don't tie him up. Get the doctor.
no, even the son told me, restrain the head, tie her. I said,
No,
no, I cannot do that.
cannot do that. Yeah, change the bath soap to sensitive skin. Yes, my
Yeah,
patient has exactly. How many of us see this, right? You want to tie them. This family says tie them up. Don't. No, you cannot. That's why I said you have to be very creative but very persistent.
yeah, that's
That's
why
right.
I even get her a jumpsuit so that she cannot scratch her butt, but it doesn't work.
Doesn't work, yeah. Well, because you didn't, if you were itchy, right, then you got to take care of that. Okay, how about if somebody's grabbing other people and grabbing other things from others? You've seen that too, right? They look at their neighbor and they go, oh, grab it. Might what? Redirect and protect both at the same time. Yeah, right. Yeah. So gotta needs to be addressed by the MD? Like, how would you like the doctor to address this? Grabbing. Stay calm and don't react harshly. Create physical space. Absolutely. Behavior meds? Is that your first job? Your first thing? That's separate the clients. Absolutely. Let's not seat them together. Maybe one of them has to spend more time outside, right? And you have to try to figure, I know the home is small, so you gotta like be creative, right? But sometimes you need to, sometimes they have to move, you know? Because if somebody's really, really irritating them, or if they're constantly walking into other people's, um, if they walk into other people's rooms all the time and cross each other's boundaries, other residents, they're going to push back, right? They grab. So don't make it, maybe they can't be in that setting. Maybe they're in another facility where um, the residents won't react like that. Like they have more dementia. You know what I mean? If they're too cognitively intact, they're going to fight, right? But if one of them is cognitively impaired and very bedbound, they're not going to get in this guy's way, right? So I guess it'll just depend. Right. Stay calm, approach the person gently, redirect them away from the other person. Make sure both people are safe and try to figure out why the behavior happened, such as confusion, fear, or overstimulation. Yes, you took like all my classes, right? A, B, C, right? And what is the antecedent? What happened before the behavior? What was the behavior and what was the consequence? Cares, right? Uh-huh. Find a better home for their safety. Sometimes, it's the environment. It's always the environment. And the problem with medicating people if the environment is wrong, right, is that the triggering problem never goes away. And you sort of you try the best you can, but if the environment is not good, then you may be forced to do that. But you do that before you restrain them. You don't restrain them because they just have dementia and trying to be themselves. Hmm. Changes is not the best. It is challenging. Oh, a pillow to hold or a stuffed object, right? They don't grab if they got something in their hands already. I have folks that there's a certain stuffed bear or a certain squishmallows are very popular these days, right? And they work too. Right? And if they're holding something, they're less likely to grab. And even, for example, if you're trying to give them a bath and a shower, right? And they're hitting you or grabbing you while you're trying to shower, give them a towel in their hand. Like they may not be actually doing the bathing, but if you give them a towel in their hand, they're probably more likely going to use the towel to work on themselves, not have free hands to grab you. Yeah. All right. Does anybody have a particularly challenging situation where you felt like you wanted to restrain them? And what did you do? Or do you want to share any good stories? You guys are all pretty good. I like your answers. And yeah, if you have any questions for me, of course, we can all try to be creative together. Sometimes caregivers' response to behaviors escalates their behaviors. Absolutely. During changing a patient who didn't want to be changed, he was full of BM, so it took 5 of us to hold him down to change him. Yes, yes. So, what would you do? Yeah, so we have to be very mindful that we need to take a deep breath and pretend like we're their best friend. Because if we try to, whoa, is somebody's birthday? If we try to react, then we will just escalate and make things worse. Absolutely. Yeah. So Oh, we have a newly admitted female resident who's always calling out for help for unknown reasons. My caregivers have redirected the calling for help into singing instead. So instead of yelling for help, she'll sing happy birthday or pearly shells. Oh my goodness. That's so sweet. Some people respond to music, right? Yeah. I had another patient who was oh, goodness. Well, everybody, right? They fight whenever you try to wash them and do pericare, right? And it was just awful. And so, because it was so hard, um, people like held them down, did it really fast, and then, you know, quickly covered him up again, right? The problem with that was he had a lot of rashes and skin problems, and I was constantly being called because oh, he has a rash in his groin. I need more medication and need antifungal lotion, need this and this and this. I said, wait, 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 wait. How is the hygiene over there? Because, oh, it's hard because he's fighting so hard that they don't let him clean. And I said, everybody? Is there anybody who can do it? One person? They said, yeah, actually, there is one guy on night shift. He's the only one he lets him clean him. I said, what's his secret? And you know what the secret was? We found out was he warmed the towel before washing him. And then I said, okay, let's all try it. Everybody, anybody, we passed that along that you need to use a warm towel. And we bought a towel warmer and everything. And you know what? He doesn't, skin is always clean. He doesn't fight the changing and the wiping and everything is much better now. And his skin, I haven't had to uh, g- uh, keep treating the skin over and over and over again ever since then. So sometimes you got to say, okay, who of all the caregivers, who does it the best? What can we learn from that person? Yeah. Okay, hold on. I'm scrolling here. So many comments. Okay. Uh, what about doctor's orders for wheelchair safety seatbelt to maintain postural support? Hmm. I guess the intention is for postural support. So it's not necessarily so they can't get out. And so as long as they can always get out, but I would still be careful about that. Sometimes if they are needing postural support, maybe they need a different wheelchair. Maybe they need a high back wheelchair or a wheelchair that can tilt back, a Jerry chair, a recliner, or something like that. Then you don't need to use one of those seat belts. Sometimes people slumping down right on their right side or their left side, and so you want to, help them sit up. But you know what? Maybe we need to just change and use different, like a Jerry chair or something like that, so that they can just be comfortable. Because sometimes if you prop them up with a seat belt or a waist thing, then they don't use their muscles there. It takes muscles to sit up, and then that can actually make them more deconditioned. So I would try to do something else. Um, okay, so here's a question about risperidol. Started to have tremors, and the doctor reduced it to 1.5 milligrams. Still have tremors, and they decreased it again to 1 milligram. Still have tremors, and the behavior is coming back again. Yes, so there are many different medications, right? There's like different classes. There's risperidol, there's olanzapine, there's Seroquel, there's all kinds, and different ones have different side effect profile. So I would try a different one. I had a patient, tiny, tiny doses. Um, you would try the quetiapine or the Seroquel, but the problem, so it didn't make them as stiff, but the problem was it kept dropping the blood pressure. And so the blood pressure was like 90 over 50, and then we always had to keep holding. the medicine was causing low blood pressure. And so we switched it to something that wouldn't drop the blood pressure, but then the behavior started. I mean, then the stiffness started. So we actually wound up giving him two antipsychotics. One to that wouldn't drop the pressure too much, and the other one would manage the behavior without too much um, extrapyramidal side effects. It's very tricky. And then we obviously want to get off of those completely and try something else. So it's constantly trying to change things and try different ones. So all the information you can give, all your observations you can give the doctor will help because there's so many kinds. I see that we run out of time. Oh, so there's an evaluation here. So make sure you do that. Go to the link and do the evaluation.
The timed up and go.
So the way you want to do the evaluation is start off with the resident that has been with you the longest. So the one that's number one is if they've been with you 5 years, they're the longest one. And then you have to answer the questions. Then you have to fill in for resident number two, the second longest resident. You would complete the evaluation, et cetera, until you complete all of your residents.
The timed up and go. Line on the floor.
And then we do want to thank you, Dr. Aida Nguyen. We always appreciate your time, your support for the community. We all wish you the best in your endeavors, and thank you so much.
My pleasure. Thank you, guys. Keep up the good work.
We appreciate you. Have a great day.